Next, I have the pleasure of introducing Dr. Christine Moutier, who will discuss the public health crisis of youth suicide. Dr. Moutier knows the impact of suicide firsthand. After losing colleagues to suicide, she dedicated herself to fighting this leading cause of death. She is now Chief Medical Officer of the American Foundation for Suicide Prevention. Dr. Moutier has served as Professor of Psychiatry at the University of California in San Diego, Dean in the Medical School, and Medical Director of the Veterans Administration Psychiatric Unit. Dr. Moutier co-hosted the CNN one-hour special, Finding Hope, Battling America's Suicide Crisis with Anderson Cooper, and recently won an Emmy Award for that. Please join me in welcoming Dr. Christine Moutier.
Good morning. As someone personally and professionally touched and affected by suicide, it is really my pleasure to speak with you all today, the very people who are caring for our nation's youth. I have no disclosures. I'd like to give a big thanks to my expert colleagues who share generously not only with me, but with the field in terms of their research and their work and their clinical findings to advance suicide prevention. So our plan in our brief time together is to take a look at the trends, to take a moment in the science to help us understand what drives suicide risk and what constitutes effective prevention. And we'll end with what can be done in the clinical setting. And I hope to provide you with some resources that you can take back not only for your own individual practice, but for your health system as well. So let's start with the national trends in mental health and suicide prevention. Science is informing culture, and the attitudes of Americans are opening up and changing dramatically when it comes to mental health and suicide prevention. The vast majority of Americans, including youth and young adults, feel their mental health is as or more important than their physical health. People's minds are open to suicide being preventable, and they say they would want to help somebody if they knew that they were struggling and at risk of suicide. The lexicon has also been changing as science sheds light on the fact that suicide, while complex, is a health issue. The word commit implies a morally reprehensible act, and we don't use that term for any other health-related cause of death. So a couple of years ago, even the Associated Press style book listened and changed their official recommendation, asking us to avoid using the phrase commit suicide, but rather using plain language like died by suicide, killed himself, or ended her life. Those are all acceptable phrases. More people than ever are opening up about their own experiences with mental health, suicide loss, or what we call lived experience of suicide. That's those who have attempted or struggled. And this kind of role modeling is sending a powerful message that it's human to struggle. It's strong and smart to get help, including treatment for mental health conditions, and that people can live well while managing their mental health. Through the work of suicide prevention advocates, including AFSP's chapter network across all 50 states, hundreds of thousands of Americans are learning that suicide, while complex, is a health issue. We teach the public that despite its complexity, suicide can be prevented. Communities are learning that a helpful intervention for people at risk is safety planning, which individualizes a plan according to the person's unique triggers and warning signs that they learn and self-reflect on and incorporate into their own safety plan to help themselves stay safe during a suicidal crisis, or even to prevent the negative spiral in the first place. And communities are learning that limiting access to lethal means is a critical part of suicide prevention and is life-saving. We are seeing state and federal laws passed for the first time in history that mandate schools and healthcare professionals be trained in suicide prevention. And several states have begun passing laws to enforce the federal Mental Health Parity Act for the first time. A new type of legislation has been introduced that you all may be familiar with called the Extreme Risk Protection Order, which provides families with a way to have guns temporarily removed from the home when a loved one is at risk and when they won't voluntarily give up their firearm. But as a nation, we haven't yet invested at the federal level in suicide prevention research and programs at an amount commensurate with its morbidity and mortality toll. Other leading causes of death, like HIV/AIDS, heart disease, and cancer, have seen drops in mortality when federal research investments were increased. The same type of investment must be made to reduce the rate of suicide in the US. We have yet to make that investment as a nation, but we will. But here you can see that since 1970, the rate had been steady, then down going through the 80s and 90s, and then unfortunately took a turn in the wrong direction. Over the last 2 decades, we've seen a 33% increase overall in the national rate of suicide in the US. When we think about the scope of the problem of suicide, we think about the 47,000 Americans who take their lives each year, including nearly 7,000 young people, 10 to 24 years old, who die by suicide each year. If any other cause of death were taking 19 young American lives per day, we would be up in arms. Additionally, 1.4 Americans attempt suicide each year, which impacts schools, families, and workplaces, and of course, all of us in healthcare. But additionally, 55% of Americans, that's the majority of us, say they have been touched personally, either through the experience of knowing somebody who died by suicide, knowing someone with lived experience, surviving an attempt or a struggle, or having our own lived experience. And these experiences are all part of the continuum of suicide prevention, which must be addressed. The unmet need of millions of Americans, youth and adults with mental health conditions who are suffering without adequate resources must be addressed. Now let's focus on youth. We're becoming open-minded about mental health, so where is the mental health literacy in our nation currently? Well, mental health conditions are highly prevalent, with 1 in 4 Americans' lifetime experiencing a mental health condition, with half of those who have a mental health condition having the onset of that condition by age 14, 75% by age 24. So why then are less than half of Americans, young and old, with mental health conditions in treatment for those health conditions? Our open mindset must translate into better mental health literacy so we can learn to recognize when our mental health deteriorates and goes beyond just everyday fluctuations and stress. So we know when to see our doctor and talk about what we're experiencing so that youth can tell a trustworthy adult if they become suicidal, which takes stigma reduction as well, obviously. In terms of health-related causes of death, among young people 15 to 24 years old, suicide outpaces all other health-related causes, taking more young lives than the rest of the health-related mortality put together. Suicide is also one of very few causes of death that continues to be on the rise. Here you see suicide rates for boys in green and girls in orange as age advances from age 10 through 24. Gender differences in completed suicide appear in early adolescence, with very low overall rates of suicide, thankfully, under the age of 12. But by age 14 to 15, the gender gap begins to widen, with boys outpacing girls' suicide by about 3 to 1. Although in the last couple of years, that gender gap has narrowed, particularly in younger teenagers, with girls' suicide on the rise. Over the past 4 decades, here are the suicide rates for male versus female adolescents aged 15 to 19. This is kind of the long view of 4 decades, just so you can see that there have been fluctuations and even decreases in young male adolescent suicide in particular, but unfortunately over recent years, it is clearly going in the wrong direction. While younger children have much lower baseline rates of suicide, The CDC report released a couple of weeks ago highlighted the disturbing trend for 10 to 14-year-olds where their suicide rate, represented by the dark blue line, has more than doubled in the last 10 years. Additionally, the trend for increasingly younger children exhibiting suicidal behavior and attempts, particularly in Black children in America, is highly concerning. Let's take a look now at what a large body of science tells us about how to understand suicide. Individual and environmental factors can create risk or protection against suicide. These factors interact, and the more there are and the more they intensify, the greater the risk. Here you can see the multifactorial nature of suicide risk that almost always starts with underlying layers of biological, psychological, social, and environmental risk factors, and then add the dynamic flow of our daily lives and stressors superimposed on those underlying risk factors. Those dynamic stressors for young people, as you well know, include relationship disturbances, traumatic experiences, losses, or contagion, the exposure of a peer's suicidal behavior or suicide, or a celebrity suicide. And we think of those life events layer as potential precipitants of suicidal behavior, but not causes on their own. And of course, the availability of lethal means is a significant risk factor as well for suicide. So while human instinct is to search for a simple answer as to the question, why, especially after an experience as shocking as losing somebody to suicide, an important takeaway is that research very clearly demonstrates that suicide is not a one-cause effect phenomenon. Rather, many risk factors and protective factors offer multiple entry points for potential intervention. This is more of a comprehensive list, not in totality, but the general risk factors that are known to increase risk of suicide for youth. The top ones, risk factors for youth suicide, include depression, hopelessness, substance use, isolation, impulsivity, and aggression. Now, among youth, mental health conditions are an almost necessary but insufficient risk factor, although, of course, mental health conditions haven't always fully declared themselves during adolescence. But there are a number of other risk factors that must be in place as well. It's not just the mental health deterioration or condition on its own. Risk factors like one's genes, parental psychiatric illness, or family history of suicide, history of ACEs, abuse and neglect, and again, exposure to peer or celebrity suicide. Again, none of these risk factors on their own cause suicide, but can contribute when other risk factors are present. Now, protective factors are equally important, and the science needs to actually move even stronger in this direction to understand how protective factors work and how can they be enhanced in the home, school, and through treatment. But we know that things like parental supervision, connection, and modeling of healthy mental health and coping strategies are protective for youth. Having effective mental health care when needed is protective against suicide. For LGBT youth, accepting versus rejecting experiences can create protection from risk. And feeling connected at school and having a religious affiliation can be protective. With that look at what drives risk and protection from suicide in mind, let's turn our attention to what can be done to address suicide as a public health outcome. In addition to increasing our understanding of suicide, science is providing interventions that reduce suicide risk in both community and clinical settings. At the American Foundation for Suicide Prevention, we set a bold goal to reduce the US suicide rate 20% by 2025, and have launched an initiative called Project 2025 that serves as a catalyst for this critically important goal to be reached. Other groups like SAMHSA, the CDC, and the NIMH have either adopted or endorsed the same goal. And as part of this Project 2025, AFSP chapters are offering to cover the cost of suicide prevention training to health systems, including your clinics, throughout the country. Now, the data showed us that if we were able to provide evidence-based strategies in key settings where people who are at risk for suicide are or where they pass through, and if we scale those interventions up nationwide, we can save the most lives the fastest. The 4 settings that showed the greatest potential for saving lives include firearm owning communities, healthcare systems, emergency departments, and correctional settings. And so just to move into the healthcare setting more squarely, which is where you all live and work, spend your time, we know that research shows 38% of children and teens who die by suicide have been seen in the month prior to their death, either by their pediatrician, in the emergency department, or on an inpatient medical or surgical unit. Patients who are at risk, though, don't often come in necessarily saying outright that they are suicidal or presenting with obvious risk. And so therein lies the difficulty. We are finding new ways to detect those times of risk for suicide and to provide a safety net through actions that lower the patient's risk of suicide. Don't feel that you're late to the game with regard to all of this. The suicide prevention field has only recently come to consensus with the evidence for life-saving treatment steps. This recommended standard care document on the left side of the screen launched just last year by the National Action Alliance for Suicide Prevention, and it includes screening and care steps for primary care, emergency departments, and behavioral health settings. And this suicide screening pathway on the right launched recently by an NIMH group under Lisa Horowitz's leadership with the American Academy of Child and Adolescent Psychiatry, with the ASQ tool validated with 97% sensitivity and 88% specificity for use in primary care, emergency departments, and medical surgical units for pediatric patients. And links to both of these resources are provided towards the end of my talk. Regulatory agencies like the Joint Commission and CMS have advanced their standards along the same lines as all of these tips that I'm going to share with you. For example, with the new Joint Commission National Patient Safety Goal just launching this summer on July 1, emphasizing a program of suicide preventive care for the clinical setting, rather than just one-offs like just screening or just a referral or crisis line. And this new Joint Commission mandate now requires suicide screening in all patients in behavioral health settings and as indicated in primary care. It also recommends a care plan and follow-up. So health systems can do several key steps with an integrated plan to prevent suicide. These include providing suicide prevention education to clinical and non-clinical staff, working into their systems of process with patient care, routine mental health, and suicide screening and assessment steps. Safety planning and lethal means counseling can be built into the care steps. And of course, clinicians and other staff need to be trained on safety planning and lethal means counseling. Of course, and you all are so good at this, involving the family as appropriate and whenever possible when a patient is at risk for suicide, and putting caring contacts, communications, after the patient leaves the clinic or the inpatient unit. Putting those caring contacts systematically in place, it has one of the most robust evidence bases for reducing subsequent suicidal behavior in high-risk patients. It seems so simple, but simply carrying phone calls, text messages, postcards. It's been well researched. And of course, document all of these actions taken. The referral to behavioral health, the communication with the family, that the safety plan and lethal means counseling were completed, providing the lifeline and the crisis text line, and all of that documentation can serve you not only to prevent suicide and reduce risk, but also from a medical legal standpoint is protective. Of course, the American Academy of Pediatrics has developed wonderful resources to equip pediatricians and families to be part of an effective safety net, like this youth suicide prevention fact sheet for pediatricians, which AAP created, that covers screening and next steps for patients who screen positive, that include all of those same recommended steps I just mentioned safety planning, lethal means counseling, referral, and caring follow-up communication. As with any major public health problem, efforts shouldn't be exclusively in the clinical setting, but need to reach out into the community setting as well. Since 2004, the Garrett Lee Smith Memorial Act has been providing SAMHSA grants to counties and tribal communities across the US that provide gatekeeper training for suicide prevention to teachers, parents, first responders, and others, and also supporting schools' suicide prevention programs. The counties with sustained suicide prevention activities under the Garrett Lee Smith Memorial Act have been found to reduce their youth suicide mortality. So suicide prevention efforts that are sustained and strategic are effective and work. Some examples of community-based suicide prevention resources and programs are the ones that we at the American Foundation for Suicide Prevention provide. These are resources for schools, clinics, families, faith communities, really it's now workplaces as well. We have resources for families to learn about what to do if you're concerned about someone in your life, and for guidance after an attempt has occurred or following suicide loss. We have youth programs and campaigns like Seize the Awkward, which is about how to approach a peer that you're worried about. It's a youth campaign. Seize the Awkward has had 1.3 billion impressions on social media, and celebrities like Billie Eilish are promoting it and talking about their own mental health, making it part of youth culture to be able to speak up if you're struggling. To find some of the resources I've mentioned, here are the links that I promised. AAP has important resources for pediatricians, patients, and families. For AFSP resources, including research videos, to find an Out of the Darkness walk or a chapter near you who would love to provide suicide prevention training to your clinic, go to afsp.org or reach out to me, please. The Joint Commission has a suicide prevention portal with recommended screening and care tools. And the youth suicide screening pathway I mentioned that's recommended by ACAP is on the NIMH website. And check out Seize the Awkward to share with youth about how to help a friend. Suicide is arguably the top major public health concern of our time. And while the goal of bending the curve and reducing the US suicide rate is daunting, there is reason to hope as the culture is changing, and importantly, science is shedding light on what constitutes effective suicide prevention. Thank you for the work you do every day with kids and families, and for being part of the effort to prevent suicide.